from Children's Hospital Boston at Harvard Medical School. He's finished his residency in New York and fellowship training at Harvard Medical School, combined MGH and Children's Hospital Boston. He published over 50 peer-reviewed publications, and he has strong interest in GI procedure and dilatation. Now he'll give us a talk on all about GI dilatation. Please, Dr. Manfredi.
Hello, my name is Michael Manfredi, and it's my great honor to speak with you all today. I'd like to thank the organizers for inviting me to the first APPSGHAN Endoscopy Masterclass. Today's topic will be GI dilation. The goals of my talk will be to discuss dilation, steroid injection, stenting, and endoscopic incisional therapy. But let's begin with the definition. An esophageal stricture is defined as an intrinsic luminal narrowing that leads a patient to become clinically symptomatic. These symptoms typically are feeding difficulties, coughing and choking during feeds, food impaction, regurgitation of undigested material, feeding refusal, and in some cases, apnea. Notice I didn't mention an esophageal diameter because there's no set diameter that defines a stricture. That being said, as a rule of thumb, this is my clinical experience, that solid food dysphagia usually begins with a luminal diameter less than or equal to 10 millimeters. Puree dysphagia usually begins with a diameter less than or equal to 7 millimeters, and liquid dysphagia with a luminal diameter less than or equal to 4 millimeters. Now, esophageal dysmotility is a confounding variable in this. Now, the cornerstone of esophageal stricture treatment is dilation. This results in circumferential stretching and splitting of scar tissue. The goal of esophageal dilation is to increase the luminal diameter and improve dysphagia symptoms. Dilation can be accomplished by either balloon dilation or mechanical bougie dilation. Now, your mechanical or bougie dilation delivers both radial and longitudinal force as it crosses the stricture. It can be passed over a guide wire, which is your typical savory dilator, or it can be passed freely into the esophagus, which is something I really don't recommend. Mechanical bougie dilation is a very tactile approach. You actually will feel resistance as you push the dilator across the stricture. Alternatively, you have balloon dilation, which delivers equal radial force simultaneously across the entire length of the stricture. Here, there's no true longitudinal force. This can be done through the scope or over a guide wire. In the fluoro picture you have here, you see the balloon being inflated, and you can see the pinch of the balloon at the area of the stricture. As the balloon is inflated, you see the obliteration of that waist, which shows that the stricture is being opened. If you are not using fluoro, all you have to do is take down the balloon, and you can notice the tearing of the stricture. Now, my typical approach to dilation is first estimate the size of the stricture. Both the diameter and length are important to know. I do this by several techniques. The easiest is knowing your scope diameter to estimate the size of the stricture. But I also use biopsy forceps. As you can see to the pictures on the right, I look at and measure my biopsy forceps open and closed, as well as the length, to help estimate the size of the stricture. I also use fluoroscopy, which I think is a very useful tool, but that's not always present for some people, depending on where they're operating. Once you determine the stricture diameter and length, that will help you set and determine the choice of balloon or savory bougie dilator to use. Classically, we're taught to adhere to the rule of 3. The rule of 3 is once you know the stricture diameter, you typically pass no more than 3 serial increasing savory dilators. Or in balloons, we adapted this to you estimate the size of the stricture, let's say 6 millimeters in diameter, and typically you would only go 3 millimeters above that. So if I would only go up to a balloon of 9 millimeters, for example, to adhere to the rule of 3. But the question comes up, do you always have to adhere to this rule? Our group attempted to answer this question. We retrospectively looked at our balloon dilations. A total of 1,384 dilations were evaluated. Our overall perforation rate in this group was found at 1.7%. When we looked at the delta diameter, we noticed that when we looked at all our dilations that had a delta change in diameter of less than or equal to 5, our overall perforation rate was 0.74%. When we looked at cumulatively all the dilations that had a delta diameter greater than 5 millimeters in size, our overall perforation rate jumped up to 4.9%. We then did an ROC curve analysis using Uden's J-index to find the point where sensitivity and specificity were maximized, and we were able to determine that at less than or equal to 5 millimeters, change in balloon dilation size was the optimal cutoff point. So possibly, instead of the rule of 3, we may have the rule of 5. A follow-up of our manuscript was done by Tambucci et al., who, in a letter to the editor, reported their experience with bougie dilations. They looked at 114 children and a total of 551 savory dilations. They reported a median increase in dilator size of 4 millimeters with a range of 1 to 7. Their perforation rate was 0.54%. They concluded that dilating to 4 millimeters with bougie dilations appears safe. They did put a word of caution that only 15% of their dilations greater than 4 were done in children under a year of age. Our experience is slightly different. Over half of our children under a year of age were dilated greater than 3 millimeters. Our perforation rate was not statistically significant compared to older children. I think overall these two studies show that when an endoscopist notes an unsatisfactory response to smaller dilation increments, there is now at least precedent to support dilating further. I think both of our groups are not advocating that you blindly go to 5 millimeters or 4 bougies in succession. You should always look and evaluate and use your best judgment. But I think there is precedent to say that you can go bigger if the clinical situation dictates it. Now, is there a superior method, balloon versus bougie? Well, the adult studies really show no difference. There were 2 pediatric studies, both of them very small sample size, that did favor balloon dilation compared to bougie. However, my suspicion is that it's really more operator comfort with either technique. I think both are equally effective. I think the really only contraindication to bougie dilation is in patients with epidermolysis bullosa, since you have the risk of injuring more areas of the esophagus. However, I'm very happy to be a part of Dr. D'Aurelio's prospective study that will be looking to answer this question. Now, if you're not getting the desired effect from dilation alone, one of the first adjunct therapies you should consider is intralesional corticosteroid therapy. Now, steroid injections decrease the local inflammation at the strictured site, thus reducing collagen formation. The most common steroid that we use is triamcinolone acetate. The concentration that I typically like to use is 10 milligrams per ml. I inject around the area of the stricture 0.1 to 0.2 milliliter aliquots. And you can see as I'm injecting here, I'm injecting into the scar tissue and trying to get a submucosal bleb. Now, again, there's not, in the stricture itself, there's not a lot of subcutaneous space. So sometimes you have to inject it above. As you can see here, I'm injecting a little bit above the stricture to get that bleb, and it will diffuse down into the scar tissue. Typically, I do 1 milligram per kilogram per dose, but we'll go up to 2 milligrams per kilogram per dose. I typically max out at 40 milligrams. Now, some people will inject prior to dilation, some will do post. Truthfully, I do it both ways, but I tend to do the injection after I dilate. Our group evaluated the efficacy of steroid injections as an adjunct therapy to balloon dilation. Our group looked at over 800 dilations and found that dilation, when combined with steroid injections, improved the stricture diameter better than balloon dilation alone. What we also found was that the improvement in esophageal diameter was seen with the first 3 steroid injection sessions. After that, if we attempted to inject steroids, the efficacy diminished drastically. Now let's turn our attention to esophageal stents. By far, the most common used stents are the fully covered self-expanding metal stents. These are made up of nitinol metal, which is a memory-shaped metal that allows you to have them compressed so they're easy to pass, and then they will expand fully, typically with heat. They're made for the esophagus, airway, and the biliary tree. Now, I typically use the airway and biliary stents more due to the size as well as the size of the flared ends. The issue with the esophageal stents are they may be commercially available in, say, a 12 millimeter or 14 millimeter diameter, but what they don't tell you is this they tell you this, but you have to look closely, is the size of the flared ends. So this stent may be 12 millimeters in diameter, but the flared end will actually go up to 18 millimeters in diameter. And so you have to be very mindful of this. So especially in smaller patients, a 12 millimeter stent may be okay, but an 18 millimeter stent would probably be too big and cause injury to the patient. So that's why I typically use the biliary or airway stents, because the flares are much, much smaller. Now, the first stents used were the self-expanding plastic stents. This is the Polyflex stent here. Because of the difficulty in placing these, as well as the migration rate, these typically have been replaced fully by using, instead most people use the fully covered stents. Something that's not available in the United States, but available for you all in Europe, is the biodegradable stent. Now, due to time constraints, I don't have the ability to talk about the dynamic stent that Dr. D'Alio has created, but it's also something that warrants attention to be as well. Now, when you place a stent, you need to have fluoroscopy. You need this to help identify the location of the stent and use it for placement. Typically, I use a fluoroscopic ruler to help us use our markings, but people have used paper clips on the outside of the patient or placed an endo clip. To go over some practical stent deployment tips, typically many stents will foreshorten as you deploy them. So you want to deploy low or below the stricture so you can pull it up. It's always easier to pull a stent up than to push it down. When possible, avoid having the stent go through the GE junction. Ideally, you want to have 2 centimeters of stent above the stricture as well as below the stricture. And something to always be mindful of is patients that have an aberrant right subclavian artery. You want to be careful not to place the stent, especially the edge of the stent, near the aberrant right subclavian artery, because there have been case reports of erosion and death. Now, why do we stent? Well, if you look at the rationale for stenting, it makes sense. Instead of doing intermittent balloon dilation, you can dilate the esophagus for a prolonged period of time. And this hopefully would reduce the risk of recurrent stricture formation. However, when we look at the pediatric literature, the reported success rate is variable, anywhere from 0% to up as high as 86%. Now, we recently looked at our stenting experience for the intent to treat a esophageal stricture. We did not include patients that we treated for an esophageal leak. We had a total of 49 patients that we treated with stenting for the purpose of taking care of this esophageal stricture. We used a total of 92 stents. The most common stent we used was the Wallflex biliary stent, followed by the Alamex airway stent. The median stent diameter used was 10 millimeters, and the median stent length used was 60 millimeters. We define stent success as not requiring a stricture resection after the stent was placed, and also reducing the number of dilations needed post-stent removal. Based on our criteria, 41% of our patients, 20 out of 49, met criteria for stent success. When we looked at the features and potential predictors of success, we saw that the pre-stent diameter in both the success group and the failure group were very similar. However, after the stent was removed, we typically looked 14 days after stent removal to reassess the stricture. In the success group, the diameter was much greater than the diameter in the failure group. In many cases, in the stent failure group, the stricture, after the stent was removed, the stricture restenosed to a similar pre-stent size, whereas in the success group, we had minimal restricturing. In both groups, the number of dilations pre-stenting and post-stenting were similar. Post-stent, we had a median of 1 dilation in the first 3 months after stent removal, and afterwards, no significant dilations. In the failure group, since most of these patients went to stricture resection, we didn't count their dilations. We found that the change in stricture diameter, this delta diameter, was interesting, and we decided to look at this further. A receiver operating curve analysis was performed to determine the discriminatory ability of the delta diameter in predicting stent success. And we found that when we removed the stent, if the diameter regressed greater than 4 millimeters, this had a positive predictive value of requiring a stricture resection or stent failure. So my take-home point with stenting is, I think it's worthwhile to try, but if we see after we're taking out the stent, we see a regression back to pre-stent diameter, we don't keep trying additional stenting. We just stop and move on to a different therapy. And why shouldn't we keep trying additional stenting? Because there are adverse events associated with stenting. This includes migration, granulation tissue, pain and retching, deep tissue ulcerations, esophageal perforation, stent erosion, and death. So stenting is something that needs to be followed very closely. In our study, we looked at 92 stents, and the most common adverse event was erosions or ulcerations, typically at the stent edges, followed by nausea, retching, vomiting. We did see leak develop in 3% of our patients. Endoscopic electrocautery incisional therapy is a technique that uses an endoscopic needle knife to make an incision into the stricture at its most dense points. An electrical surgical generator applies a cut current to make the incision. Now, typically, after the incision, a balloon dilator is then inflated to allow preferential tearing where the incision is made. These are my two favorite needles that I use. The one on the left is a IT Nano knife. This has an insulated tip, so it prevents accidental puncture into the esophagus at the needle tip, which is probably its most dangerous. The knife I use actually more commonly is this Hubric knife by Cook. The reason I like it is the diameter is small, that I can actually use it through a 2 millimeter channel. So when I'm using this on a very small infant and I'm using a XP Olympuscope, which is just 5.4 millimeters, I can use this needle. Now, if we look at this stricture on the top left, if we ended up placing a balloon in the center of this stricture and we exerted force equally in all directions, where is it going to tear? It's going to tear at that weak spots there and there. And what will happen is you'll have an ineffective balloon dilation. However, by doing incisional therapy on the thicker parts of the stricture that I'm outlining here, and then balloon dilate, you're going to have a more effective dilation. Now, for ERBI generators, I use EndoCut I, effect 2, cut duration 2, cut interval 3. When we looked at our data, we looked at EIT in 36 patients who had a recalcitrant stricture. They had at least a median of 8 dilations prior to EIT. The number of dilations on average following EIT was 2, and we reported our success of treatment at 61% in this recalcitrant stricture group. In our non-recalcitrant stricture group, we had 100% success. Overall, a 76% success rate with EIT in all of our patients. Now, EIT is not without risk. We report an overall adverse event rate of 5.3%. Now, when we break this down, 3% of these were small contained leaks that didn't require any additional therapy other than conservative treatment. We did have, in 2% of the times, a more free-flowing, non-contained leak that did require either stenting or a wound vac. So definitely the risk is higher than typical balloon dilation. I like to end this talk showing this video. This is a very recalcitrant stricture, which has a very thick scar shelf that compromises close to half of the diameter. In this video, I performed incisional therapy where my goal here was to really carve out that shelf of tissue. Almost like if you were using a melon ball scooper trying to scoop out the scar tissue. That's what I was trying to do here. Once I kind of carved out as much of the stricture as I felt safe with, I then followed this up with a balloon dilation to further stretch that tissue. But now, after I did all this incisional therapy, what's to prevent it from restricturing down? This is where I feel stenting has a benefit. I placed the stent to prevent the stricture from reforming where I made those deep cuts. Now, after a week or so with this stent in place, you can see already, just after 7 days, how much ulceration and erosions are just at the tip of that stricture, the tip of that stent. And that's only a 10 millimeter stent I have placed there. And we can see that looking at that, there's still, the tissue is very raw, and there's still a little bit of residual scar tissue that I did some additional therapy on, and I ended up placing a bigger stent this time around. After I removed this stent, I injected this area with steroids, and you can see that the shelf is almost completely gone. And this patient clinically has done remarkable. So I do feel EIT with stenting potentially has some benefit, but warrants further investigation. So in conclusion, dilation is first-line therapy, although it's still unclear if balloon or bougie is a superior technique, but use the technique you're more comfortable using at this point in time. Dilate till you see an effect. Don't limit yourself to strict numbers. Esophageal stenting is not super effective at 41%, but based on our data, I think a short duration of 2 weeks of stenting may be worthwhile. The change in diameter post-stent removal may be predictive of your outcome. Endoscopic incisional therapy is a useful technique for experienced endoscopists. I think that combining EIT with stenting warrants further investigation. I want to thank you for your time and attention.